Hello, everyone, and welcome to Med Games with your host, Ken Jennings.
Hello, learners, and welcome to Med Learning Group's Patient Progressions program, which is full of rich medical education content in a game show format. I'm Ken Jennings, and I'll be your host for this CME activity. In addition to learning from our expert faculty and interactive case studies that will assist you in treating your patients, you'll learn more about the patient's perspective, which will assist you as you navigate the shared decision-making process for their individual health journey. Now, we'll begin the program by asking a series of multiple choice questions designed to show how well you know your patient. We will then reveal the actual answers that patients selected in our recent patient survey, demonstrating how well you know the patient. MLG has worked with a variety of partners to survey a representative sample of patients to develop this program. Additionally, throughout the program, you'll be asked a series of questions regarding treatment, management, clinical trials, and safety and efficacy information.
And now, we'll hear from our program chair.
Hello, I'm Dr. Nirmala Gonsalves, Professor of Medicine at the Division of Gastroenterology and Hepatology at Northwestern University and the co-director of Northwestern Eosinophilic Gastrointestinal Disorders Program. Welcome to our program targeting type 2 inflammation in eosinophilic esophagitis. Update your knowledge. Here are my disclosures for this talk. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals and Sanofi. Learning objectives for this program are to summarize the role of type 2 inflammation in the pathophysiology of eosinophilic esophagitis and challenges in diagnosis, appraise off-label therapies and deficiencies in the management of eosinophilic esophagitis, and to evaluate current clinical data concerning the use of novel therapies targeting type 2 inflammation in eosinophilic esophagitis. So let's get started. All game show questions will be asked again at the end of the program as a post-test for CME credit. Now, let's kick off the game show with your first question for 100, 200, or 300 points.
It's time for our first round. Please select a category to get started. Great choice. Now, how many points would you like to play for?
For 100 points, histopathologically, EOE is confirmed by a peak count equal or higher than
Oh, sorry. That wasn't the correct answer. But don't worry. You'll have another chance to answer this question at the end of the program.
The definition of eosinophilic esophagitis is that it is a chronic, immune-mediated, food antigen-driven disease. Patients need to have symptoms related to esophageal dysfunction. One or more biopsy specimens must show eosinophil predominant inflammation. With 15 eosinophils per high-powered field in a peak value is considered a minimum threshold for the diagnosis of EOE. Inflammation needs to be isolated to the esophagus after ruling out other causes for eosinophilia. Eosinophilic esophagitis has a global presence, as you can see here on this map. There are reports of this disease across all continents with the exception of Africa. Prevalence ranges from 45 to 100,000 in adults and 100 to 100,000 in pediatrics. This slide highlights the prevalence and the incidence has been increasing over the last several decades. On the left, you see an increase in incidence rising across all areas that we just saw. On the right, you also see an increase in prevalence trends. This affects at least 1 in 2,000 people in Europe and the US. It is the most prevalent cause of dysphagia and food impaction in children and young adults, and the second most common cause of chronic esophagitis. Here's a schematic that looks at the pathophysiology of EOE. We'll start off on the left. This is a normal appearing esophageal epithelium. In response to food and air allergens, that creates inflammation, which stimulates allergic cytokines such as IL-33 and TSLP, which then stimulate other inflammatory cells such as Th2 lymphocytes. This sets off a cascade of inflammatory cytokines, including IL-4, IL-13, and IL-5, which help draw eosinophils and other inflammatory cells like mast cells to the esophageal mucosa. At that point, you can see changes of remodeling, loss of barrier function, and esophageal inflammation. Let's look a little bit closer at the actual eosinophil. This is a picture of a cell called an eosinophil. On the cells, there are various chemokine receptors, Fc receptors. Inside the cell, there are a lot of cytotoxic granule proteins, which can cause a lot of inflammation once that cell gets activated and degranulates. Ultimately, that can lead to epithelial barrier dysfunction, fibrosis, repair intolerance, and this is all driven by Th2 inflammation and eosinophilia. All of that inflammation actually leads to the clinical presentation in adults. In adults, this is a male-predominant disease in about 3 to 1. This presents in the 3rd or 4th decade. 70 to 80% of patients will have an atopic history, meaning they may have asthma, allergic rhinitis, or atopic dermatitis. 71% of patients have been reported to be white. However, this can be an unrecognized phenomenon. Recent studies suggest that this can affect non-white populations, and it's likely underreported. If you ask patients, they may give you a family history of EOE or atopy. Dysphagia or difficulty swallowing is the most common symptom in about 70 to 80%. And I have a double asterisk here because it's not important enough to just ask patients if they're having difficulty swallowing, because oftentimes they'll say no. They have dealt with these conditions for many, many years, and they start to accommodate for their symptoms. They may chew excessively. They may take in small bites of food. They may lubricate their food so it slips down. So really, it's important to do a deeper dive into that history and ask them about their symptoms. Patients have learned to accommodate for this to prevent the dreaded complication of food impaction, which is food lodging in the esophagus, which can happen in 33 to 54% of patients. Other common symptoms include heartburn and reflux and chest pain. These are the typical findings we see on endoscopy. In the upper left corner, you'll see these concentric mucosal rings, which is a sign of fibrosis or scarring in the esophagus. Furrowing, which are those linear creases in the esophagus, look like railroad tracks, are a sign of inflammation. In the bottom left panel are white exudates, which almost look like Candida, but they actually represent eosinophilic microabscesses. And on the bottom right panel is that dreaded complication of food impaction in a patient who has concentric mucosal rings, edema, and furrowing. And that's actually a piece of chicken in one of my patients who came in at 2 o'clock in the morning to the emergency room. Now let's think about the prevalence of EOE compared to other allergic or atopic conditions. As we mentioned, EOE affects about 34 per 100,000 patients. Now, when we think of other eosinophilic disorders, such as eosinophilic gastroenteritis, this is much more rare, affects 5 to 8 per 100,000. Now, let's compare this to other allergic conditions like asthma, which affects 7 to 8% of the U.S. population. Seasonal allergies affect 40% of the U.S. population. And interestingly, 78% of patients with EOE had more than one atopic condition. Now, doing a deeper dive into that esophageal mucosa, here are the histologic features of EOE. And it's a little bit more than just the eosinophil. What you see here at the top of the slide are the pretty pink cells with bilobe nuclei, and those are the eosinophils. They're up at the top of the specimen, and that's what's called superficial layering. You'll see areas where they clump in more than 4 in a group, and that's called eosinophilic microabscesses, and that corresponds to those white speckles you saw on the last slide. The spongiosis, or the white areas in the bottom part of the slide, is a sign of intercellular edema or swelling of those cells. Epithelial hyperplasia, degranulation, or breaking apart of those cells, and lamina propria fibrosis are also seen. And if you look at a certain part of that slide in what's called a high-powered field, you need to have more than 15 in order to make this diagnosis. Here is a slide that looks a little bit more at the eosinophil in health and disease. Now, the primary location of eosinophils are that they reside in the GI tract. They're a helpful role in homeostasis and fighting off infection, and they're involved in Th2 disease and inflammation. The role in non-Th2 disease are less clear. So you see the eosinophil in the middle of this slide. In response to certain activating signals, that eosinophil can get activated. It can stimulate other cells into that area that ultimately can create epithelial differentiation and function, tissue repair and fibrosis, and can lead to bronchospasm in certain diseases. I highlighted a bit of pathophysiology earlier in this program, but I'd like to show you this again because it is really important to understanding this disorder. So in response to food and air allergens, eosinophils start trafficking to the esophagus. And how does that happen? The response to the food and air allergens stimulates inflammatory proteins. Important proteins include IL-4, IL-13, and IL-5, eotaxin 3, IL-33, TSLP, just to name a few. They then attach to cellular receptors, which then recruit other inflammatory cells to come to that tissue and ultimately lead to esophageal inflammation, lamina propria fibrosis, esophageal dysmotility, and epithelial permeability, which all lead to that esophageal dysfunction. In the eosinophil, what happens and how that eosinophil actually creates some of that inflammation is that eosinophil is chock full of these granule proteins, as I mentioned earlier. When that eosinophil gets stimulated, it breaks apart. Those cytotoxic proteins spill out into the tissue, and that results in activated and or damaged epithelium. This can induce expression of remodeling factors such as endothelin-1, TGF-beta, just to name a few, and that ultimately leads to the scarring and fibrosis of that esophagus. So what are treatment goals for patients with EOE? Well, in clinical practice, treatment goals are not only focused on histologic efficacy. We want to improve symptoms. We want resolution of dysphagia without the need for that patient to avoid food based on texture. We definitely want improvement in histopathology. We want resolution of esophageal eosinophilic inflammation, ideally less than 15 eosinophils per high-powered field. And we want improvement in endoscopic changes, improvement in the inflammatory features and strictures, and ultimately getting that esophageal diameter over 15 millimeters. So how can we accomplish that with management of EOE? I'll review recent data from the AGA clinical guidelines on proton pump inhibitors, topical corticosteroids, and dietary therapy. And now for another game show question.
You've hit a daily double. Let's watch a quick video, then answer a question for 300 points.
What did you call it? what?
Eosinophilic esophagitis. I know, it's quite a mouthful. I just call it EOE.
So what is it?
Eosinophils are a type of white blood cells found in your GI tract. They can typically be found in the stomach, small intestine, or colon, but not in the esophagus. The esophagus is the muscular tube which connects your mouth to the stomach, and when eosinophils are in the esophagus, they can cause inflammation, which can lead to scarring of the esophagus, which leads to troublesome symptoms like difficulty swallowing.
What causes it? Did I do something wrong?
When eosinophils are in the esophagus, it could be due to a condition called acid reflux or to EOE, or in some cases an overlap or a combination of the two. When these eosinophils are present, they can create a lot of inflammation and damage to the esophagus. That's typically what creates those features we saw on the endoscopy, the scar tissue and narrowing, which is why you've been having difficulty swallowing and you feel like something's caught in your throat. This happens because of your body's response to different allergic substances, such as food or things in the environment.
So, what do we do about it now? How do we cure it?
So there is no cure, but there are excellent treatments that can help you feel better. EOE is considered a chronic inflammatory condition of the esophagus, which means once we start a treatment that works, we keep you on it to make sure the inflammation is staying quiet. One option is a medication called a proton pump inhibitor that reduces the acid in the esophagus. This helps heal some of the damage you have. It also has some anti-inflammatory effects on the esophagus. Another option in terms of medication is swallowed topical corticosteroids. These medications are asthma inhalers that you swallow into your esophagus instead of inhaling it into your lungs. It reduces inflammation, which helps get rid of the eosinophils. Neither of these are FDA approved, but we use them off-label for EOE since previous studies using these medications have shown good benefit. There's also a new medication that the FDA recently approved called dupilumab. It's a biologic therapy that works to target certain allergy-causing proteins to help reduce those eosinophils in the esophagus and reduce swelling.
Well, it's good to know that it's treatable.
It can also be treated with diet, the idea being that EOE may be caused by food allergies. In this case, chronic exposure to common foods can lead to the eosinophils entering the esophagus and causing inflammation. Dietary therapy consists of taking out all potential food triggers, then adding them back one by one to see which one might be the culprit. All these options are very effective. It just depends on your goals of care and what fits best with what you want with therapy. So maybe you can share that with me?
Well, the food thing doesn't thrill me. I really enjoy food and wine, and I don't want to get rid of all that. So if we try the medication, do I still need to do the diet?
No. We typically choose one path or the other. So if you do a medication, we'll pick which medication is the best fit for you based on your preferences. And we'll plan on a follow-up endoscopy in a couple of months to see if the treatment's working.
This new medication you mentioned, what kind of side effects does it have?
Dupilumab is injected into the fat under the skin, so there might be some redness and swelling in those areas. There can be some respiratory infections or reactivation of viruses like herpes. Other common side effects seen in the clinical trials include allergic conjunctivitis, so redness of the eye, muscle and joint aches, fevers, nasal pharyngitis, which means inflammation of the nose or throat, and headaches. Usually these are all self-limited, meaning they go away when you stop taking the drug. Overall, however, it's a well-tolerated medication.
I don't know if I like the idea of injecting myself. The other two, which would you recommend?
It's really your preference in terms of which you'd like to try. They're both effective. The most recent guidelines suggest an effectiveness of between 40 to 50% for the acid-reducing medication and 60 to 70% of the swallowed topical corticosteroids.
And what are the side effects of the steroids?
They're also well tolerated and very safe. The most common side effect is Candida esophagitis, or thrush, which is a fungal infection we can treat with medication. Depending on which one we use, you'll either spray it into your mouth or swallow a special liquid. The proton pump inhibitor is a pill you take once a day, about half an hour to an hour before eating. Side effects are rare, but can include headaches and diarrhea. It's usually a well-tolerated medication. If you start either of these medications, we would repeat your endoscopy in about 8 weeks to make sure it's working. You'd then remain on the medications for what we call maintenance therapy. If we stop these medications, the inflammation will come back, so guidelines advise chronic therapy.
Well, let's start with the steroid. I guess we can always do something else if that one doesn't work.
Daily double. All of the following are true except
Nicely done.
So let's start with proton pump inhibitors. Here we see data from the AGA guidelines on management of eosinophilic esophagitis and how they position proton pump inhibitors or PPIs. The recommendation are in patients with symptomatic EOE. The AGA and Joint Task Force guidelines suggest using PPIs. Now, this is a conditional recommendation with very low quality of evidence. Now, when you see the data in the guidelines, they show you a forest plot for not achieving histologic remission. So good studies are actually on the left as opposed to the right. And that's a little bit backwards on what we think about in terms of treating EOE. So I have flipped the data for you a little bit and put at the bottom the percentage achieving histologic response, because that is really how we think about treating these patients. So with PPIs, the percentage achieving histologic response is 42%. This is data from the European EOE Connect database with 630 patients, which show that PPIs reduce symptoms and endoscopic features of EOE in children and adults. On the left, you can see symptomatic improvement in 71%, so blue bars are good, red is bad, and on the right, histologic improvement in 48%. That study further went on and showed that PPIs improve fibrostenotic features of EOE. On the left, you can see improvement in endoscopic reference scores or endoscopic changes in that esophagus in patients who have been on PPIs compared to swallowed topical corticosteroids. And on the right panel, you can see that there has been an increase in luminal diameter after treatment with PPIs. So what are practical considerations for PPI therapy in EOE? Well, this is a popular first-line treatment due to widespread availability, ease of administration, and safety. It's no longer required for the diagnosis of EOE. It's actually moved into treatment. Histologic benefits in children and adults are variable, approximately 30 to 50%. And the loss of therapeutic benefit with prolonged use is reported, but uncommon. It's time for your next question for 100, 200, or 300 points.
Great choice. Now, how many points would you like to play?
For 200 points, which of the following is FDA approved for EOE?
Good job. You got it.
Well, this is going great. You've been really engaged in this content. Please don't forget to utilize the point-of-care tools such as the personalized poster portal, animations, and web portal, which are available to you on demand at any point. These tools have been designed to support reflection and translation of your knowledge gains into practice. They've also been designed to be used in practice with your patients to improve communication and help your patients and caregivers understand complex information about their disease and treatment options.
Now let's move on to what we know about topical corticosteroids. Here's the data from the AGI guidelines on management of eosinophilic esophagitis and topical corticosteroids. The recommendation is that in patients with EOE, the AGA and Joint Task Force guidelines recommend topical steroids over no treatment. This is a strong recommendation with moderate quality of evidence. And the percentage achieving histologic response is 65%, so quite good. There have been some follow-up studies since the guidelines. This is one looking at budesonide oral suspension in patients with EOE and dysphagia who are 11 to 55 years old, who were randomized in a 2-to-1 fashion to receive either budesonide oral suspension or placebo. You can see the data and their outcomes at the bottom. They had a stringent histologic response of less than 6 EOs per high-powered field in 53% of patients compared to 1% on placebo. And on the right, you see also an improvement in the dysphagia symptom response of greater than 30% reduction in the DSQ score compared to placebo. There's been another study looking at a budesonide oral dispersible tablet, or BOT, and that has been shown to induce EOE remission. This was a prospective phase 3 randomized double-blind placebo-controlled multi-center study. It's a parallel group trial enrolled 82 subjects for 6 weeks. Patients needed to have active EOE, and it was a 6-week, twice-daily treatment with BOT 1 milligram, and it was found to be safe and highly effective for achieving the following endpoints. Their primary endpoint was a combined endpoint, a clinico-histologic remission, which you can see here on the left panel. And that was achieved in 57.6% of patients in the treatment arm compared to 0% of placebo. If you then break down that treatment into the various endpoints of clinical remission, histologic remission, and endoscopic remission, as you go over from the left to the right of the screen, you will see impressive improvement in clinical remission, histologic remission, as well as endoscopic remission in the treatment arm compared to placebo. Another study has been completed looking at fluticasone propionate orally disintegrating tablet, or APT 1011. This was a phase 2B trial in 106 adults with EOE who received 1 of 4 doses of the medication or placebo for a 12-week induction and 40-week maintenance. The primary outcome was histologic response of less than 6 eosinophils per high-powered field at week 12, and the secondary outcomes were endoscopic features and dysphagia frequency. And here you see their data showing an impressive improvement in histologic responders at week 12 on the left, week 26 in the middle, and week 52 on the right compared to the placebo. So what is a practical approach to the use of swallowed topical corticosteroid therapy in EOE? Well, the current treatment is given for 8 to 12 weeks. Fluticasone typically 0.44 milligram to 1 milligram twice daily, and there are lower doses in pediatrics. Budesonide 0.5 milligrams to 1 milligram twice a day. Adverse effects such as esophageal candidiasis, oral thrush, and adrenal insufficiency are uncommon. It's time for your next question for 100, 200, or 300 points.
Great choice. Now, how many points?
For 300 points, all of the following are true except
Looks like that wasn't it, but don't worry. You'll have another chance to answer this question at the end of the program.
Let's move on now to dietary therapy. So the AGA and Joint Task Force guidelines on the management of eosinophilic esophagitis on dietary therapy. The first we'll look at is elemental diet. The recommendations are in patients with EOE. The guidelines suggest using elemental diet over no treatment. This is a conditional recommendation with moderate quality of evidence. And the percentage achieving histologic response is 94%. So by far, this is one of the more effective treatments, but elemental diet can be quite challenging from a cost, palatability standpoint, and the long reintroduction process for patients. So therapy has really shifted a bit to empiric elimination diet. And at the time of the guidelines, they had data for the 6-food elimination diet. And the recommendations are in patients with EOE. The guidelines suggest using an empiric 6-food elimination diet over no treatment. This is a conditional recommendation or low quality of evidence. And the percentage achieving histologic response is 68%, so quite good. What about allergy testing directed diet? Patients ask about this all the time. And the recommendations are in patients with EOE, the guidelines suggest allergy testing based diet over no treatment. This is a conditional recommendation with very low quality of evidence. And the percentage achieving histologic response was 50%. Now, despite that, there is a caveat there because the certainty assessment was rated down due to single-arm cohort studies and high inconsistencies. As you can see here on the forest plot, the studies are really all over the map. So the guidelines also specify that patients may prefer alternative medical or dietary therapies to an exclusively testing-based elimination diet. Those larger effect sizes were seen in pediatrics that combined ATP patch and skin prick testing. So in younger patients, that may be a reasonable approach. Since those guidelines came out, there have been numerous other dietary therapies. Here is a graph that compares dietary therapies for EOE in children and adults. You see elemental diet at the top is by far the most effective. Then there's been that 6-food elimination diet, which eliminates milk, wheat, soy, egg, peanuts, tree nuts, fish, and shellfish. A 4-food elimination diet, which eliminates milk, wheat, soy, and egg. A 2-food elimination diet, milk and wheat, allergy testing directed diet, and a single food with dairy at the bottom. And what you can see here is that as you eliminate fewer and fewer foods, that effectiveness does tend to decrease. Since the guidelines, there have been 2 randomized diet studies in EOE. The one on the left is the PCORI study, which looked at a milk-only elimination diet versus a 4-food elimination diet in children. The one on the right is the SOFIED study, which looked at a milk-only elimination diet and a 6-food elimination diet on the right. The histologic response and remission was defined as less than 15 eosinophils per high-powered field. And what you can see here in these slides is that the single-food elimination diet was not all that inferior to a more extensive elimination diet. So in some patients, that might be a reasonable place to start. At Northwestern, we also did a study looking at the real-world experience of this 6-food elimination diet in clinical practice. We had 213 patients over the span of 15 years who completed the 6-food elimination diet. 54% had a full histologic response, which actually improved to 58% with subsequent rounds of diet therapy. And 69% had only one food trigger identified after the reintroduction process. So this is helpful information to share with any patient who's motivated to do diet therapy. So what is the practical approach to the use of diet therapy in EOE? Well, diet therapies are effective first-line options for children and adults with EOE. Empiric elimination diets have advantages over elemental and allergy testing-directed diets. Multiple empiric elimination diets are available. You saw that slide 1, 2, 4, 6, a step up or step down. Consultation with a dietitian for patient education is very helpful. Food reintroduction is essential to identify those specific food triggers for patients, and the timing of diet initiation is important for success. For instance, if you have someone who's traveling a lot for work, or a kid who's going away to college, or if you're hitting the holiday time, it may be best to just move dietary therapy to when their schedules are more predictable. Let's move on now to what we know about monoclonal antibodies. It's time for your final question for 100, 200, or 300 points.
Great choice.
For 300 points, what percentage of patients using swallowed topical steroids?
That wasn't correct. Better luck next time. Try again at the end of the program.
The first I'd like to highlight is dupilumab, which is an anti-IL-4 receptor alpha monoclonal antibody. This inhibits the signaling of IL-4 and IL-13, and it was previously approved for multiple atopic conditions, including atopic dermatitis, eosinophilic asthma, and chronic rhinosinusitis with nasal polyposis. This is data from dupilumab anti-IL-4 receptor in a phase 2 study in adults with EoE, and found to reduce dysphagia, esophageal eosinophilia, and endoscopic activity. On the left here, you see symptoms, in the middle, histopathology, and on the right, endoscopy. And what you can see here on these slides is that the treatment arm had a significant reduction in symptoms, esophageal eosinophilia, and endoscopic inflammation compared to placebo. This is data from the Phase 3 or Liberty EoE Treat Part A study, which looked at co-primary endpoints and found that dupilumab significantly reduced dysphagia and intraepithelial eosinophil counts at week 24. On the left graph, you can see an absolute change in the DSQ total score from baseline, and it was significant with dupilumab compared to placebo. And on the right, you can see patients achieving peak esophageal intraepithelial eosinophil counts of less than 6 at week 24 was achieved in 59.5% of patients compared to 5% in placebo. The Liberty EoE Treat Part B study has shown 159 EoE patients who are greater than 12 years old, studied clinical and histologic efficacy and safety of dupilumab 300 milligrams per week versus placebo for 24 weeks. You can see here on the left, the percent reduction in symptoms measured by the DSQ was found in 64% of patients in the treatment arm compared to 41% in placebo, and 59% reduction in the eosinophil count less than 6 compared to 6% in placebo. And these studies largely led to the FDA approval of dupilumab in May of 2022 in patients over the age of 12 for the treatment of eosinophilic esophagitis. Additional data from the Phase 3 pediatric trial, 1 to 11 years. This was a primary endpoint of histologic disease remission with a secondary endpoint of abnormal endoscopic findings and changes in caregiver-reported symptoms by the PSQC. The results of the study showed that 68% of those on the higher dose and 58% of those on the lower dose reached the primary endpoint versus 3% on placebo. Children on the higher dose demonstrated a 3.5-point reduction in abnormal endoscopic findings versus an increase of 0.3 points for placebo. And sub-analysis demonstrated higher dose resulting in 3.09 percentile increase in body weight for age percentile from baseline compared to 0.29 for placebo. Moving on now to what we think about in terms of maintenance therapy for these conditions, and the guidance on maintenance therapy really comes from what we know on EoE natural history, which shows diagnostic delay and fibrostenosis can occur, and this has been found to be consistent results in 4 separate studies. I'm going to highlight 2. What you can see here on the left panel is that the prevalence of fibrotic features increased from 47% at 2 years to up to 88% with a diagnostic delay of over 20 years. What you see in the right panel is that for every 10-year increase in age, the odds of that fibrostenotic phenotype more than doubled. And that really led to this guidance from the AGA on management of eosinophilic esophagitis. And at that time, they had data available from maintenance with topical corticosteroids. And they say in patients with EoE in remission, following short-term use of topical corticosteroids, the guidelines suggest continuation of topical corticosteroids over discontinuation of treatment. This is a conditional recommendation with very low quality of evidence. And what is some of that evidence? This is data from the budesonide oral dispersible tablet multi-center prospective maintenance trial. They had 204 patients with EoE in histologic and symptomatic remission following induction therapy. Patients were randomized to BOT 1 milligram twice daily, 0.5 milligram twice daily, or placebo, and their primary endpoint was the proportion of patients in remission with a relapse defined as symptoms greater than 4, eosinophils greater than 15 after 48 weeks. And you can see the data on the right showing that the percentage of patients in remission at week 48 was 75% in the high-dose arm, 73.5% in the low-dose arm, compared to only 4.4% on placebo. So this study also showed that the median time to clinical relapse was over 350 days in the treatment arm compared to only 87 days in the placebo. Further support for maintenance therapy comes from this study here, which was a retrospective study which analyzed 206 adults for a median time of 5 years. And what the graph shows you is that patients who remained on swallowed topical corticosteroids were much less likely to have food impactions compared to patients without steroids. And this really drove home the point that topical steroid treatment really improved inflammation and outcomes in EOE. So what is the rationale for maintenance therapy in EOE? Well, EOE is a chronic disease with symptoms in esophageal eosinophilia which persist without treatment. Both medical and dietary therapy can be effective maintenance treatments. Consider reduction in that corticosteroid dose with prolonged use. If you do dietary therapy, pursue food reintroduction to liberalize that diet and identify triggers. And there's near universal recurrence if that treatment is stopped. The guidelines also suggest the use of EGD with biopsy to assess disease activity after a change in therapy is reasonable. Let's move on now to biologics and emerging therapies, our current knowledge and recommendations. We'll start off with anti-IL-5 therapy in EOE. First one is mepolizumab. This is a humanized monoclonal antibody against IL-5. There have been several studies that were completed in pediatrics with variable results, and one currently recruiting in adults. Reslizumab is an IL-5 neutralizing antibody. There was a clinical trial with 226 children and adolescents, which found a reduction in peak eosinophils compared to placebo. Treatment groups did not meet significant improvement in symptoms. So at this point, the role of IL-5 therapies are uncertain, but we eagerly anticipate the current studies that are ongoing. Moving on now to cendakimab, which is an anti-IL-13 antibody. This is a recombinant humanized monoclonal antibody, which is highly selective for IL-13. They completed a randomized, double-blind, placebo-controlled phase 2 clinical trial in 99 patients ages 18 to 65. And their primary endpoint was a change in mean esophageal eosinophil count. And here we see their data that cendakimab reduced eosinophilic inflammation. This was the randomized double-blind placebo-controlled trial in 99 patients ages 18 to 65. What you can see here on the left panel is an impressive reduction in mean eosinophil count in both the low-dose and high-dose treatment arm compared to placebo. On the right, you can see an impressive reduction in endoscopic reference scores in both the low-dose and high-dose arm compared to placebo. Their secondary endpoint was a mean change in symptom score based on a daily symptom diary. On the left, you can see that reduction in the overall population. While there is a separation in the high-dose arm compared to the low-dose arm in placebo, it was not significant. On the right again, if you further look at the subgroup of the steroid refractory group, you'll see an even further separation in the high dose versus the low dose on placebo, but these results did not meet significance. What are other things in the pipeline for therapies for EOE? Well, lirentelimab is a cyclic 8 monoclonal antibody completing phase 2 and 3 trial in EOE. Benralizumab is an anti-IL-5 receptor, which is completing a phase 3 study in EOE. Etrasimod is an S1P receptor modulator completing a phase 2 trial in EOE. Cendakimab, an IL-13 monoclonal antibody completing a phase 3 trial in EOE. And molecule 1104, which prevents monocytes from stimulating dendritic cells into activated T cells, is completing a phase 2 trial in EOE. Additional therapeutics include tezepelumab, which is an anti-TSLP. It's completed a phase 3 trial in asthma, done a proof of concept study in HES, and is doing a phase 2 trial in EOE. And an anti-IL-33 compound, which has completed a phase 2 trial in asthma. So now that I've gone through many different therapeutic options, how do we put this all together? Well, this was a clinical decision support tool developed by the AGA on the treatment of EOE. So if you have a patient who you've diagnosed with eosinophilic esophagitis, you can start medical therapy with proton pump inhibitors, topical corticosteroids, and now given the recent FDA approval, you can add dupilumab to that arm. Or you can start dietary therapy with empirical elimination diet favored over elemental formula or allergy testing directed diets. If patients don't respond, you can switch to the other arm. If they do respond, then you want to keep them on maintenance therapy. And if at any time there's a clinically relevant esophageal stricture, you would perform an esophageal dilation to get rid of that obstruction. So let's move on now to some clinical cases. The first case is a 36-year-old male who presents with persistent dysphagia for 6 years. He's had 5 emergency room visits for food impactions, and he has ongoing symptoms despite chewing carefully and drinking water with his meals. He often avoids eating at business lunches or dinners. He has a history of atopic conditions such as asthma and allergic rhinitis, and he returns for a consultation in the gastroenterology clinic. So what is the next step in his clinical care? A, obtain blood work to check for nutritional deficiencies. B, proceed with a time-barium esophagram with ingestion of a tablet. C, order a manometry to assess for motility causes of the dysphagia. D, proceed with endoscopy and biopsy of the esophagus to make the diagnosis. Or E, start a proton pump inhibitor and have him return to clinic only if he does not have symptomatic improvement. And the answer to this question is D, proceed with endoscopy and biopsy of the esophagus to make the diagnosis. There were several clues in that history that should alert you to a diagnosis of EOE. He was a young male, persistent dysphagia, several episodes of food impaction, and atopic conditions. EOE is the most likely diagnosis in this scenario. The gold standard for making this diagnosis is endoscopy and biopsy of that esophagus. So you then do an endoscopy, and this is what your endoscopy shows. On the left panel, you'll see a severe proximal esophageal stricture with a narrow caliber. On the right is his barium esophagram, showing a narrow caliber esophagus approximately 10 millimeters across, and that stricture is actually quite narrow, about 3 to 4 millimeters across. Biopsies were taken of his esophagus and showed 85 eosinophils per high-powered field in that proximal esophagus and 100 eosinophils per high-powered field in that distal esophagus. So all the following treatments are appropriate therapies for his condition except A, inhaled topical corticosteroids twice daily. B, dietary therapy with an empiric 6-food elimination diet. C, weekly dupilumab 300 milligrams subcutaneous injection. D, start patient on omeprazole 40 milligrams once daily. And E, swallow topical corticosteroids twice daily. And the answer to this question is A, and the key is that word inhaled topical corticosteroids. So when we treat patients with EOE, first-line therapies include medical therapy and dietary therapy, swallowed topical corticosteroids, proton pump inhibitors, recent approval of dupilumab, and dietary therapy with a favored empiric elimination diet. The patient decides to start therapy with PPI and topical corticosteroids. The endoscopy 12 weeks later shows proximal counts of 65 EOs per high-powered field and distal of 40 EOs per high-powered field. Since that therapy didn't work, he then transitioned to a different therapy where he proceeded with a 6-food elimination diet and felt better. However, his repeat endoscopy showed a proximal count of 35 per high-powered field and a distal count of 41 per high-powered field. It should also be noted that esophageal dilation was performed because if you have a patient with severe stricturing of the esophagus, that is important to do in addition to medical or dietary therapy. So despite doing all of these things, he had ongoing histologic eosinophilia. So what do we have next? At this point, he transitioned to dupilumab injection because he had failed PPIs, swallowed topical corticosteroid, and elimination diet. Let's move on to the second case. This is a 32-year-old female with a history of dysphagia and self-limited food impactions who presented to the emergency room with a food impaction. The endoscopy revealed endoscopic changes of EOE and biopsies were taken. The patient was placed on omeprazole 40 milligrams once daily. Repeat biopsies showed 60 eosinophils in the distal esophagus and 70 in the proximal esophagus. Now, the patient relays to you that there are numerous inhalers for their asthma and topical corticosteroids for their allergic rhinitis, and has recently been diagnosed with secondary adrenal suppression. She also works as a chef and cannot pursue an elimination diet. So what are appropriate next steps in treating this patient? A, pursue an elemental diet therapy. B, continue PPI therapy and perform annual esophageal dilation. C, start on high-dose swallowed topical corticosteroids. Or D, weekly dupilumab subcutaneous injection. And the answer here is D. And so let's go through these one by one. Option A would not be appropriate because due to her work environment being a chef, doing a dietary elimination is not her choice. Option B is not appropriate because you already know that there's persistent esophageal eosinophilia on that PPI. There's clear evidence that we need to improve that esophageal eosinophilia to prevent that ongoing stricturing. So dilation alone is not thought to be a good monotherapy and is advised against. And starting on a high-dose swallowed topical corticosteroid, while quite reasonable, in her would not be the right choice because of the history of adrenal suppression, which could be worsened in this case. So in this case, the right answer is D. So the treatment with dupilumab is initiated, and the patient returns in 2 months for a clinical visit. She reports that symptoms are improved and she feels well. Endoscopy is scheduled in 12 weeks and reveals a reduction in eosinophilia to less than 15 eosinophils, as well as improvement in dysphagia. So in conclusion, hopefully what you've learned from this program is that eosinophilic esophagitis is a chronic immune-mediated inflammatory condition of the esophagus. Pathophysiology is related to genetics, food allergies, and other environmental factors, including Th2 immunity. Common clinical presentation includes dysphagia and food impaction in adults, and reflux, vomiting, abdominal pain, and failure to thrive in children. Progressive fibrosis can occur with longer duration of disease, so earlier diagnosis and treatment is important. Treatment options include proton pump inhibitors, swallow topical corticosteroids, empiric elimination diets, and recently dupilumab. And future studies focusing on emerging biologic therapies appear promising. Thank you very much for joining our program today.
It looks like you are a winner. Great job on answering the tough questions, and thank you for being so invested in your patient's care. Thank you again, one and all, for tuning into our program, and we hope you enjoyed the Patient Progressions game show activity. Med Learning Group looks forward to your participation in future events and appreciates all that you do for your patients. Please remember to complete your post-test and evaluation and attain your credit for attending. This is Ken Jennings signing off as your program host. Be well and take care.
Try taking our post-test to improve your score.
For 100 points.
Hey!
For 200 points.
Nicely.
For 300 points. All of the following are true except
Oh, sorry. That wasn't the correct answer.
for 300 points.
Good job.